Sorry, that's the lady in the computer, not me, saying that the recording is in progress. We are recording this presentation. This evening, we have a talk entitled A Novel Surgical Approach to Reverse Obstructive Sleep Apnea. Our speaker is Associate Professor Rushdi Hendricks, who is in the Division of Pulmonology in the Department of Medicine at the University of Cape Town. Rushdi graduated in 1979 with a dental degree from the University of the Western Cape and qualified as a specialist maxillofacial and oral surgeon in 1986, and has had a private practice for over 3 decades, but has also continued teaching. He's been a consultant for 2 military hospitals for 3 decades, and he has gained extensive experience in trauma surgery and has a PhD, which he achieved in 2017 in surgery, which he received from UCT. And he is now a consultant in the Department of Plastic and Reconstructive Surgery at the University of Cape Town. So we're going to ask Professor Hendricks in a moment to share his screen and to give us his presentation. Just to say, for those of you who have just joined us, we will have this as a presentation, and afterwards there will be an opportunity for questions, but please do feel free to use the chat box. And hello, Ed, nice to have your greeting there. And anybody who would like to make any comments during the presentation is welcome to use that chat box to do it. But we will have an opportunity to talk at the end of this. So Professor Hendricks, if you would like to unmute yourself. You are muted at the moment because everybody is, but if you could unmute yourself and then share your screen, and we're very much look forward to hearing your presentation. So thank you.
Thank you very much, Professor Burton. I feel really honored to be invited to this occasion to talk to so many people whom I know, in fact. But I would just like to say a little special moment for me here. I'm sitting with Dr. Stephen Craven next to me and Carolyn McGibbon, but Stephen and I come a long way. We used to operate together, and Stephen introduced me into this auspicious society way back in 1997. So it's a bit of nostalgia for me to sit over here and talk, be on the other side for a change. I used to enjoy listening to these wonderful lectures from the Royal Society over the last 24 years. I just want to say welcome to everybody. It's the first time I'm doing a virtual presentation, so I hope it goes down well. I want to talk to you about a novel surgical approach to reverse obstructive sleep apnea. And I am in the Department of Pulmonology as an honorary professor, but I'm also a senior consultant in the Department of Plastic and Reconstructive Surgery. Now, sleep apnea can be divided into 3 parts: obstructive sleep apnea, central sleep apnea, and mixed or complex sleep apnea. The most common type is obstructive sleep apnea, which is what I have my special interest in. Central sleep apnea happens when there's brainstem injury, and the complex sleep apnea happens when there's a combination of obstructive sleep apnea with central sleep apnea. So let's carry on with obstructive sleep apnea. Obstructive sleep apnea is a chronic debilitating medical condition. You could call it a sleeping disorder. And it is characterized by apneic episodes. In other words, episodes when one does not breathe, and also associated with other episodes where the breathing is shallow. We call that hypopnea. So, but there has to be at least 30 episodes in a 7-hour sleep period, and the episodes must be at least 10 seconds long. Usually it is accompanied by a drop in oxygen tension inside the bloodstream. Now, the index that we use to quantify it and qualify it is called the apnea-hypopnea index. We also use the respiratory disturbance index, which is a more accurate index, but a more difficult one to calculate. Sleep apnea can be divided into 3 forms: mild, moderate, and severe. So for the mild form, we have 5 to 15 events of apnea per hour, moderate 15 to 30, and severe apnea more than 30 events in an hour. And again, there's a 3 to 4% reduction in the oxygen tension in the blood. Now, there's always been this question about snoring. Does snoring cause sleep apnea, or is snoring something on its own? Well, it's a question of, the answer is, yeah, there's a little bit of both. Snoring is not abnormal. People think it's abnormal, but it's actually a normal physiological function. And why do we snore? We snore because there's airway resistance inside our pipes or our airways. And that was something that was described by Poissier's law of hemodynamics and aerodynamics quite a long time ago. But let's go and talk about the Venturi effect, which was originally described by Daniel Bernoulli. And here we're talking about when a pipe, when there's an increase in movement of air or fluid through a pipe, that part will narrow and create a pressure gradient. And normally it sucks air in. This is how car carburetors work, for example, which I have a picture of over here. So that due to the Venturi effect, we can hear the sounds of snoring in our airways. So does snoring cause obstructive sleep apnea? Of course it does. Now let me explain to you how that works. When you lie in bed on your back and your mouth is closed and you're only breathing through your nose, then the air passes over your soft palate, like an aeroplane's wing, just above the soft palate. That we call single-sided snoring. But when your mouth opens, then air also passes below your soft palate. And now you have a flutter effect because you now have the Venturi effect on both sides. And that flutter, like the tail of a bird, is what creates the sound of snoring. However, there is a third type of snoring, which a lot of people don't actually recognize and know about, and that is tongue-based snoring. Tongue-based snoring is a flutter of the base of the tongue, usually below 100 hertz, about 20 hertz. It is below our hearing capacity. So we don't actually hear people snoring on the tongue base, but this is where sleep apnea comes in. If you look at single-sided snoring, and you can see how the air goes above the soft palate over here, that creates the one effect, okay? Then when your mouth is open, you have double-sided snoring, and the air goes below the soft palate, and now you have the flutter effect, okay? Then the tongue-based snoring happens over here at the base of the tongue. And usually, as I said, it's a quiet form of snoring. Now, when we look at Young's modulus of elasticity, and we're now talking about the tonus of the tongue muscle, the intrinsic muscle of the tongue is actually very, very, how can I say, it's not a strong muscle. It's almost like porridge. It's not very strong, well thick, millibug porridge, that type, you know. Anyway, so here we go. When we see, there's the tongue with its base, and normally the kPa here is about 60 kPa, and when this reduces down to 10 kPa, kilopascals, the tongue is in a softer state. And what happens then is that if you put this into the formula of Young's modulus of elasticity, the tongue will move backwards to be almost 3 millimeters away from the posterior pharyngeal wall. And that is when the tongue moves and occludes the airway. So the elasticity of the tongue, the modulus of elasticity, is determined by Young's modulus, and the tonus is determined about how you sleep at night, how deep you sleep. Did you drink alcohol? What did you do to make this go down? And in some people, it's just natural that it happens, overweight, obesity, and so forth. So this is how snoring and tongue-based movement can eventually occlude and cause obstructive sleep apnea. Just out of interest, the soft palate usually gets wedged in between the tongue and the posterior pharyngeal wall. And that is how the occlusion happens. So what happens with sleep apnea? Well, people feel tired during the day. There's personality changes. They put on weight because of the reversal of the leptin-ghrelin cycle. They become depressed because they don't like the way they look. They feel tired. There's an increase in road traffic accidents. Also, a massive increase in comorbidities like hypertension, stroke, pulmonary hypertension, in particular, heart failure, right-sided heart failure, cardiac arrhythmias, diabetes because of metabolic disturbances on the cellular level, erectile dysfunction, which is a very important problem, and carbon dioxide retention, cyanosis, as well as premature death. How does all these comorbidities happen? Well, it's quite easy to work it out. When you lie in bed at night and your tongue occludes your airway, you are basically being choked. And that's the same thing as somebody putting their hands around your neck and just choking you for a while. So what happens? Your body responds with a flight reaction, and it releases catecholamines and cortisol. And these circulating catecholamines have the deleterious effects of creating hypertension and all these comorbidities that I'm showing you. Now, how about children? What happens to children? More or less the same thing. However, they suffer from ADD, attention deficit spectrum, behavioral changes, emotional disorders, and learning problems and memory. So it's also a very important thing not to overlook OSA. And these days, we see parents are not afraid to let their children become obese. It's actually quite shocking to see this happening. How significant is the problem? Obstructive sleep apnea makes up about 1 billion adults around the globe, about 13%. And it relates well to other diseases like asthma, ischemic heart disease, hypertension, and stroke. And how significant is it in our country? Well, we're looking at about 36%, about 21 million people, and worldwide, of the billion, at least 425 million require active treatment. Now, if we look at the BRIC countries like Brazil, we're looking at about 40-odd%, Russia, also close to 50%, and India, also 40%, but look at the 40%, it's 500 million, it's 500 million people. And China, we're looking at 750 million people. And what we see in blue here are the 10 most popular countries for sleep apnea: America, Brazil, France, Germany, Nigeria, Russia, China, India, and Pakistan. And how significant is the problem in the Western countries? Well, it's around about the 50% figure again. Germany and France and United States of America, around about 50%. In the United Kingdom, also around about 50%. What is the cost of treating people with obstructive sleep apnea? In our country, we're looking at about 22 billion Rand per year in a recent study done by a student from Stellenbosch University. And worldwide, we're looking at 165 billion US dollars per year in the US of A, and in Europe, about 1.9 billion euro. Now, how does sleep apnea occur in a different, looking at from, I've shown you now from the snoring side. When you inspire or when you breathe air in, you create, there's a negative pressure inside your airways. And the airways will want to collapse, but it is prevented from collapsing by the action of the tongue muscle. The tongue muscle is attached to all these other muscles in the pharynx that keeps everything in a good tonus and what we call compliance. So the tensor veli palatina, the genohyoid styloid muscle, these are the muscles that would normally collapse, but the tongue keeps it all in the right place. But when you sleep, especially when you're lying supine on your back, these muscles become hypotonic. And when that happens, the compliance is lost. There's insufficient compliance to prevent intraluminal pressure causing the obstruction. But what does the brain do? The brain is smart. The brain, there are 4 levels of sleep. So we usually sleep in levels 3 and 4, but the brain pushes us up to levels 1 and 2. So we arouse very quickly so that we can breathe again. Otherwise, we will die from hypoxia or hypoxemia. So what happens is that people with sleep apnea do not get good quality sleep. They don't dream. They don't have quality REM sleep. They are miserable during the day. They come home and they fall asleep. Now, if we look at the airway from a different perspective, for example, people with neck circumferences more than 40 centimeters, or obesity with truncal obesity, or they have a lot, or they're sleeping on their back, this can push the airway inwards. Then again, if you have obstruction inside the airway at the nasal level, the oral level, and the hypopharyngeal level, this can cause obstruction. And then the third one is if you drink alcohol before you go to bed, or you're taking heavy drugs to sleep, like sleeping pills, you can also have tonus loss due to deep sleeping. And the shape of the airway, for example, in China, why do they have sleep apnea when most of those people are not obese? There we're talking about the shape of the airways, which are narrow airways. So all these things lead to one problem, and that is it all leads to collapse of the upper airway. Now, the genoglossus of the tongue muscle, as I said before, is the most important predicator. And there is another article by a chap called White, very good article, showing you what an important role the tongue plays in bringing all these muscles under tonus and keeping your airway open, because everything else impacts negatively upon the airway. So how do you examine a patient with sleep apnea? What do you look for? They have these short necks, and they have sometimes small mandibles or setback mandibles and narrow nostrils, steep palates, increased body mass index. And when we look at the places where people obstruct, this is a normal airway. The soft palate, and that is the tongue base, and that is the hypopharynx. And normally you have a triangular shape of airway behind the soft palate and the tongue. However, in sleep apnea, you've got a thin, narrow, lengthened airway, almost like a string-like look. And if you look at it in cross-section, you'll see that the airway is small and narrow. And if you look at this MRI, you'll see the fat around the neck pushes into the retropharyngeal area and the parapharyngeal gutter, and that is what makes your airway so narrow. And look how easy it is for a person like this to obstruct during the sleep. A normal airway is about 11 to 13 millimeters wide, and a sleep apnea airway is about 2 to 4 millimeters. So how do we evaluate these people? We look at their nose, we look at inside the mouth, and we look down their throats. And the nasal airway, which we're showing over here, can be obstructed by narrow nostrils, wide columella base, luminal nasal valve strictures, and also a very important one is obstructive turbinates, wide, big turbinates, so you can see how big they are, and also a nasal deviated septum. So we go to the ENT surgeon, and the ENT surgeon tries and fixes those things for us. That's called level 1. Then we're looking at adenoid tissue in the upper airway. And then we come to the oral cavity, where one has a narrow upper jaw or a narrow lower jaw, retruded upper jaw or lower jaw. Look, this is a very retruded lower jaw, okay? And you can classify the size of the tongue and how this airway looks. The anesthetists love to use the Malin-Party classification to see how difficult the intubations are going to be. Macroglossia is something you find a lot with sleep apnea because, in fact, fat deposits inside the tongue with obesity and with sleep apnea. And here we can see the carnations of the tongue, how it sits against the teeth. And believe it or not, this person is lying under anesthesia. And look how big this tongue is. It's overflowing over the teeth. So in these people, one would have to make their tongue smaller if you're going to advance it. Otherwise, they'll bite their tongues. If you look further in the mouth, you'll see hypoplastic soft palate and uvula, constricted pillars fauces, a long uvula hanging down. And look at the tonsils over here. All these things cause obstructive sleep apnea. And also, when you look deeper down in the hypopharynx, you can see parapharyngeal fat pads. That's also, as I showed earlier, how the fat comes in from the side. So when we look now at a person from the side, this is a cephalometric tracing. This is the main giveaway, is a steep mandibular plane angle. And this means, and I'll explain to you now how the growth of the skeleton causes sleep apnea. But basically, we have this problem of a narrow airway over here. Look, a normal airway is about 11, and look how little that is. So if we look at a patient like this, we'll see the retruded chin, retruded upper jaw, retruded showing upper lip with a gummy smile, nasal prominence, short neck. And if you look at the cephalometric tracing again, you'll see this high occlusal plane angle is the giveaway in sleep apnea patients. They have a short mandible, they have vertical downgrowth of the anterior maxilla, they have posterior vertical hypoplasia and anterior posterior hypoplasia causing mandibular hypoplasia, all causing a reduction in the oropharyngeal airway. An orthodontist will look at this and tell you that this is a sleep apnea patient. How do we suspect sleep apnea when we go around talking to people? Do you snore? Do you wake up and you're unable to catch your breath? Is it difficult to breathe through your nose? Are you predominantly a mouth breather? Are you tired during the day? Do you have to take a nap during the day? Do you fall asleep while you drive or at school, or do you have difficulty in swallowing? Now, firstly, the medical management of sleep apnea, obviously, a lot of these people are overweight. So we put them on a diet, on a weight loss program, exercise. But the main form of treatment medically is CPAP, which is continuous positive airway pressure where you sleep with a mask. And then you have to manage the comorbidities. Oral appliances have limited use in sleep apnea. The surgical treatment is tonsillectomy, adenoidectomy, straighten up the septums, uvulopallative laryngoplasty, which I'll show you, the hyoid suspension, mandibular advancement, bimaxillary advancement, and tracheostomy. Now, here is a dental appliance which brings the jaw forward, and you can see it's used for mild sleep apnea only. But the dental appliance, which people tend to prefer over CPAP, by the way, has also got problems. It is limited on the level of sleep apnea it can treat, and there are long-term disadvantages like TM joint problems, occlusal problems, and myofascial pain dysfunction. So if you look at CPAP, you can see people have to sleep with CPAP, but they don't like it. Why? Because air is being forced down your airway. And that's okay if your airway is open. But if your airway is partially obstructed, it can be very, very uncomfortable for you. So the CPAP spins the airway in a forward position and the air goes nicely down. And I tell you, if you sleep with this machine, the next day you feel like $1 million. You feel amazing because your brain gets proper oxygen throughout the night. But what is the problem with CPAP? It's non-compliance. And why is there non-compliance? Because these are the issues with sleeping with CPAP. You know, sinus issues, skin issues, issues with feeling claustrophobia and the noise it creates and the sexual embarrassment, and then it goes on and people just don't want CPAP. So CPAP fails in the long run. Why? Because you have to have CPAP for at least 4 hours per night and at least 7 out of the 10 nights. And you only land up, most people only land up using CPAP for 2.7 hours. Why? They pull the mask off in their sleep and they just can't handle it. Now, in children with sleep apnea, the orthodontist can deal with people with narrow maxillas. They just expand the maxilla. It's called rapid maxillary expansion. But look at the magic. If you take a narrow maxilla and you just expand it at the back, look what happens to the airway. This narrow airway suddenly opens up and becomes a beautiful airway, which we can see over there. So people with narrow airways with sleep apnea in children, all they have to do is see the orthodontist, put on the braces, expand, put in the expander, and you've dealt with the sleep apnea. Now we've looked at the medical side. Let's look at the surgical side of how sleep apnea gets handled and what are the problems. The gold standard for surgery is tracheostomy, but who wants to walk around with a pipe coming out of your throat? That's not very nice. So we take out the airway obstruction. We do the UPPP, which used to be very popular. Suspend the hyoid bone, advance the chin, advance the mandible, advance both jaws if you want to. So tracheostomy, not a very popular thing, but very much life-saving, especially in children who are born with sleep apnea. There are children born with small mandibles, and there are children born with no mandibles. So yes, tracheostomy has its place. Then the UPPP is a very painful operation. I've had it, and I can tell you the results of it is not amazing because food can regurgitate up your nose after you've had this procedure. And it only lasts for about 50%, 6 months. It has a success rate of only 50%. I don't think it's a great procedure, but it also helps. It's one of those many procedures that ENTs have to make some money from. Geniohyoid advancement is when you advance the chin, and that also has limited benefit. And you can also suspend the hyoid bone, also limited benefit. This procedure is very good, and that is when you break both jaws and you counter-rotate it. In other words, counterclockwise rotation. So you break the upper jaw, which is called the Lafort 1 osteotomy. You break the lower jaw, which is called a sagittal split osteotomy. And then you can counter-rotate the complex like this. Here we go. Lafort 1, sagittal split, and you can also bring the chin forward. And in so doing, you can take a long, thin, narrow airway and make it into a short, wide airway, which is the healthy airway that one has to have. So it's a very successful procedure, and I'll show you pictures now of how this airway gets improved from a narrow airway to a wide airway doing this double jaw surgery. But there's risk involved. It's expensive, and you need a lot of technology here. And also you need to wear braces, and it's a mission to go through this. But there are people who do. You can see over 600 operations in the United States in 2011. And look at that beautiful airway over here, created by double jaw surgery. So what is the magic number to bring this tongue forward if we want to mitigate obstructive sleep apnea? So they did a study to look at mandibular advancement, and they found that 10 millimeters is your magic figure. If you can bring the tongue base forward by 10 millimeters, you'll get the best result in increasing the posterior airway space. And that, I must just tell you, by serendipity, was the number that I actually used when I did my first study on this. It was just a guess. Let's look at the unsuccessful surgical attempts to deal with obstructive sleep apnea. The repo system, which is now defunct, is a method of bringing the tongue base forward by putting a suture through the tongue base and then tying it to the inside of the lower jaw. It lasts for about 6 months, and then the suture tears through. And look at the evidence. It was studied by Muller in 2002, 20% success rate. Handlier, 2013, same procedure, repos, fails. And then what they did was they tried something a little bit fancier in dogs, and they put a pulley into the dog with a little barb. And why is it not going to work? I can tell you now why it's not going to work. The tongue muscle is soft, and these barbs are going to tear through. And that's exactly what happened in these dogs. These barbs embedded with a bit of fibrosis, but after 6 months, everything failed. They tried to then use the same method in humans, and they had to stop the research. And because they couldn't find any reason why they should continue. Barbs were breaking, and it was unethical to continue. So Woodson published in 2010 and said that the system is designed to fail. So if you go onto Google today and you look up tongue advancement procedures, you'll find out that this Airvan system, you can't even buy it anymore. It used to be marketed by Medtronic. I wanted to buy one for myself, and I just couldn't buy it. So at the moment, as I speak, there is no device that you can buy to mitigate sleep apnea through the tongue advancements. So let's look at what is the problem with the tongue. I've been talking about this tongue for a while now. The tongue, unfortunately, we are the only mammals on the planet where the tongue sits in our throats. All other animals, the tongue sits in their mouths. But animals don't have conversations like I'm having now. And I think because a tongue sits in my throat, I can articulate and phonate, and there's more sophistication involved. But the downside of it is that I can now get obstructive sleep apnea because the tongue doesn't have a check tendon. If you look around your joints, you've got check tendons all over your body, your elbows, your knees, your joints, your TM joints, your jaws. Check tendons protect the movements, but the tongue has got nothing to protect it. So at night, it can just fall back and obstruct. And if you stimulate the 12th cranial nerve, which Van der Heijden has shown here, and you attach to the 12th cranial nerve a little electrical lead, then the tongue actually jumps forward. And it just shows that you can mitigate sleep apnea by advancing the tongue. So what is the solution? The solution is, let's create a check tendon. Let's put something over here where the blue line is. Let's run it from the chin to the base of the tongue. But let's do something and use something that can be biological. But before we do that, let me tell you what I did way back in 2012. I spoke on the radio one day, Radio Sona Grenze, and a lot of farmers answered my call the next day. And they said, please, I hear you've got a surgical procedure that can, treat sleep apnea. And I said, yeah, let's take a try. We just signed some consent papers and off we went. And I used the medical aids in private practice. For those of you who are a bit squeamish, I just want to warn you, these pictures are not that nice to look at. You can always turn your head away. I won't be long with it. But to expose the chin inside the lip, I make a little cut in the vestibule, and then I expose the button of the chin. Take out the outer table, and then to prevent the inner table falling into the floor of the mouth, I put a screw in there, and then I pull out that bone, so now I've got access to the floor of the mouth. Then an incision on the dorsum of the tongue. The tongue needs sharp dissection, and you don't tear the muscle. And then you can put in your little retention sutures. And then what I did was I used polypropylene, which is the mesh used for treating hernias in the abdominal region. And this is a non-absorbable material. So I use this mesh anchor, and then I test it to see if it works, and push it through the hole that I made in the chin. And then I measure 10 millimeters with a pen, and I put a screw into the chin, and I tie that mesh to the screw, and there we are. So if you see a little lingual valley, I call it like this. Yeah, there's the lingual valley. Then it means I've brought the tongue forward enough. And 5 of my 10 patients had huge tongues. So what do I do with them? They're going to bite their tongues if I just advance it. So in their cases, I simultaneously remove the middle third of their tongues like that. And that takes away about 30% of the weight of the tongue. And that's why I say there's a lot of fat inside the tongue. I can actually see the fat. And this is called a keyhole procedure. It looks like a keyhole or a fish. And I take out the midline of the tongue, midline section of the tongue. And then on the left, you can see what's called a fork tongue. And on the right, you can see a strawberry tongue. And now in that, I put my retention sutures once again, same protocol, put the mesh in and advance the tongue. And then I close the tongue up in a normal way. It doesn't look so amazing when you suture it up, but, and it looks like it's been really battered. And you can see my pen there. I'm using a 10 millimeter advancement protocol, and then put in the screw, close it up nicely. As I said, not a pretty sight right now, but look how beautiful it looks. Firstly, I must just say that these patients are high risk. So we keep them intubated overnight in high care or ICU, and then we extubate them the next morning. And I've got a very powerful team of pulmonologists and physicians around them, because these people are high risk anesthetic patients. Anyway, so there's the tongue lying nice and beautiful now after having been reduced by 30%. And I also do radio frequency on the uvula. And let's just look at the results of these cases. This was an anecdotal study. There was no controls, and it was really not that highly ethical, but none of these patients complained, and they were happy what I did to them. Look how their airways have improved. I drew pictures on it and measured the airways, and then I used, because I didn't have money to do sleep studies on these people, I used a subjective scale called the Epworth sleepiness scale, which is 8 different positions or situations that you find yourself in, and you can chart from 0 to 3. So 8 times 3 is 24. Okay, so now let's just look at the results. These were the people before they had the surgery, and a month to 6 months later, none of them had any more reason to have sleep apnea or to sleep with their CPAP machines. If we look at this one, we can also see how these numbers have come down dramatically. In fact, if you look at the pink here, you'll see in some of them, they've even disappeared down to 0. So even though this was a subjective report, I did publish it though in the Annals of Maxillofacial Surgery in 2019. So it was good enough to get into a respectable journal. And that is the article that I published way back then. So now I had the proof of concept. The proof of concept says that you can bring the tongue forward using a device. And now I thought to myself, how can I create a device which can be natural? In other words, something that God did not give you. Okay, so before I get to that, let me just give you a few of the results of the study that I did. The only sleep study that I could pay for and the patient paid for, but post-op with this technique, was looked at by a sleep doctor, and look what happened. The patient had hypertension. 6 months later, the hypertension disappeared. Interesting result, eh? And if you look over here, we can see the sleep doctor said no indication for CPAP therapy. Responses from patients, very, very emotional responses. People, their lives have changed, their sex lives have changed, they dream, they have energy during the day. You know, I have a whole list here of all the nice things these people had to say. And this was up to 7 years later. Still saying that none of them actually needed to sleep. Look, I'm having dreams for the first time in 15 years. So these people are now enjoying deep sleep. And that is just because they had this procedure of having the tongue base advanced. So another point is that not all sleep apnea patients are obese. This gentleman had severe sleep apnea, and he was not obese at all. This is a gentleman where I made his tongue smaller, and he said he's lost his R, and he can't breathe so nicely anymore. But look at the main statement: he does not use his CPAP machine anymore, and that's an important one. So that brings me now to what this lecture is all about, and that is the biological tendon that I've developed a few years ago. And this is what the tendon looks like. It's made up of porous polyurethane, which makes up the active ingredient. This is basically a tissue scaffold. And the strength is provided by polydioxanone over here, and we make these little buttons with it. Now, this is the implantable device, and that's how it looks. It's where I'm using it for a sheep study, an animal model. And so we don't have to be too sterile, but I had to go through a whole rigmarole of ethics and so forth. Here we can see what it is. If you look at the scaffold under high power, we can see we have these porogens that you wash out, and then it makes these beautiful channels into which stem cells can grow and lay down collagen. And the size is 120 microns. Now, the Elizarov Gavril is the gentleman that came up with the law of tension and stress, and that is, if you're just going to put these scaffolds into people or into animals, fibrous tissue will just grow in. But you need to stimulate this by stressing it, like moving the tongue, swallowing, pushing the tongue forwards and backwards. And this law of tension and stress is what makes the collagen line up in parallel lines. So I did the sheep study. I used 22 sheep in 2015. I went through the whole ethics and drew up a protocol. There's the ethics approval. And then I used in private practice a horse theater, because there was nothing better at the time for sheep, because most vets usually only work on dogs and cats. They also work on birds and so forth, but I couldn't find a theater that I could work with. So in Newlands, I found the Blue Cross Theater. And then I went to Grootersdorp Hospital, and I found some of these old parts, and I got a technician to make up my own anesthetic machine. And here you can see a highly skilled nurse. These are called anesthetic nurses. They intubate the sheep, and they look after the sheep under anesthesia. And that is a veterinarian doctor that we see over there. And the sheep become intubated orally, and we also put a big tube into, because the sheep has got 3 stomachs, and they have a lot of fluid in there, and they tend to regurgitate the fluid while you're operating. So we suck the fluid out. And here we can see the technique of putting my device in. I'm going to play you a short video now, just to show you how the device gets in. Go. Just hold on for a moment, and you'll see. Just see again. Let's go back. Here's the video. Yeah, now it's working. So this, I'll go through this video quite fast, just to show you. I make a cut in below the chin of the sheep, and I expose the lower jaw, the bottom of the mandible or the lower jaw of the sheep. And then I do a bit of blunt dissection to get towards the base of the tongue. And you can see there's not much bleeding involved. Then I put a suture through the tip of the tongue so that I can pull the tongue forward. The sheep has got a very long tongue, and I need to get down to the base of the tongue. And here we can see there's the tongue base over here, and I do sharp dissection. You can't use blunt dissection, because you'll just tear the intrinsic muscle of the tongue. And here we can see now the dissection taking place, and I will put in tracking sutures to assist me to open up the wound. And I can just show you how I sew the side of the wound to the cheek of the sheep, just to make life easier for me to dissect down further. And I do the same on the opposite side. So I will just fast forward that a bit now. And then I put the device in. Now you can see the device has got 4 sutures attached to it. So 2 sutures for one side and 2 sutures for the other side. And all I do is I make a knot between the 2 sutures on either side, and that secures the device very firmly into the base of the tongue of the sheep. Okay, so there we can see I've done that. And then we can move forward a bit again. And then once the device is nice and secure, I do the pull-through method. It's done. Yeah, So here we can see now I use an interesting instrument which is blunt in front and opens like a mouth of a chicken or something. And I push this instrument through blunt dissection in the middle of the tongue so I don't hurt any vital structures like arteries and nerves. And there one can see the mouth of the instrument over here. And I then feed the loopy side of my device into that instrument, and I do a pull-through procedure. And that pull-through procedure allows the device to go towards the lower border of the mandible. And then we just close the dorsum of the tongue. And there you can see I'm playing with the device, pulling it, and it's got nice and secure. And we have to put tension on this device, as I said earlier. The law of tension and stress has to help us to grow the collagen in parallel lines, which we'll see later on histology. And then I'm closing up the defect, and we can fast forward that now. That's all just very basic. And then when I open up the lower border again, and then I use a water cool drill and drill into the lower border. You can see it bleeds copiously. And now I use a tapping instrument to first tap a thread into it. And then we use this polylactic acid screw that goes into the buttonholes. Now remember that these buttonholes are 10 millimeters apart. So it makes it easy for you to know how much you are advancing the tongue. Okay, and this is a very strong screw. It's 9 millimeters long, and we use it for fractures in children. So it's quite strong, even though it's made from a resolvable material called polylactic acid, which disappears within 6 months to a year. And there we can see a nice firm result. And now we can just close the wound. And normally just close the wound in layers. And I must tell you something interesting. You know, when we wake up as human beings from an anesthetic, we like to lie down and sleep a little bit because we're tired. But when a sheep wakes up from an anesthetic, the first thing it does is it bumps its chin onto the ground, and that is to balance itself. And then it stands on all fours. And only when a sheep is successfully standing on all four, its legs, then we say it is fully recovered and out of danger. And that's something I learned during this escapade. Then these sheep were explanted by me after a few weeks. I did 6 sheep after 8 weeks. And look at this beautiful result. There's the tongue, there's the chin, and there's the tendon starting to grow. Okay, that's magic. And in my control series, we can see the polydioxanone is getting thinner and is becoming friable and fragile. And then we make cuts of it and look at the histology at 8 weeks. And what do we see? Inside, we see all these pores, these channels are like a little factory, like a mincemeat machine, making collagen for us. And here we can see the collagen lying in parallel lines. This, I couldn't tell you how high I jumped from the floor when I saw that my hypothesis actually worked, that I can actually grow collagen types 1 and types 3 in animals. And here we can see the polydioxanone. There's the factory that makes the collagen. And the green in the Masson trichome stain, this green is the parallel collagen that we see. So is this really collagen, or am I just fooling myself? Well, if you don't want to fool yourself, then go and see Professor Sharon Prince. She'll tell you. She is there in the molecular biology. There's a new collagen. Sharon Prince and company helped me. There's a polydioxanone. And we cut this up into little pieces, put them in there, homogenization with mortar and pestle, break it down. I don't do this. Sharon Prince's company does it. The students, it's a postdoc student here. And then with sonication ultrasound, we can get, and centrifugation, we can get a supernatant, and then do Western blotting on it. And woe and behold, collagens types 1 and types 3 identified in sheet number 2. And here we can see the results of the Western blotting, collagen types 1 and types 3 after 8 weeks. This was one of the most exciting days in my life when I actually found out that I could actually grow collagen. Before that, I was toying with ideas in growing collagen using hydrogels, and I found that not to be necessary. And I must just at this juncture mention that Professor Dion Bezuidenhout was busy growing blood vessels in the cardiac unit, and he is the man that helped me to develop this device which is made up of all these polyurethane pores. And here we can see the screw that I put into the chin and how the screw is becoming attached to the bone. And then we went on to the phase 2 of our study. And remember, I did these cases on human beings where I put the polypropylene mesh into their chins. Well, I took that mesh material and I put them into sheep to see what actually happens to it. And we'll see the results just now. Then in the test group, I looked at a control group of only PDO or polydioxanone, and then the test group of polyurethane with polydioxanone. And then we implanted 16 more sheep. We then explanted them 16 weeks later, which is halfway through the study. And we can see now what happened to the polypropylene. It just becomes fibrosed. It is non-absorbable, non-toxic, and it just stays there. Then if you look at what happens to the screw, you can see the beautiful attachment of the device to the bone of the mandible. And if you start looking at the device itself, it's not looking like a device anymore. It's starting to morph into a different shape. And this is the beginning of a tendon-like tether. And look how strong it is. Look at what I put onto this thing. It can actually handle more than 60 newtons of force. And this is at 16 weeks. We can see the mature form of collagen, again, types 1 and types 3, measured in kilodaltons. Then looking at the histology at 16 weeks, what a beautiful picture. Here we can see the collagen being produced, and again in parallel lines to the lines of force, according to Elizarov, the factory making the actual collagen tendon, and there we can see the mature collagen around it. And that is in higher power. We see the breaking down of polydioxanone into carbon dioxide and water later on. These are just fragments looking like pieces of glass. And on high power, we can see the fragmentation of the polydioxanone taking place and the beautiful collagen laying itself down in parallel lines. So that is the middle part of the study. And here we can see the biological bond between the device and the bone. There's the 4 strands, and there is the new bone forming this bond with collagen. Then to test it, it was a bit difficult to do this bench testing because it's a slippery little tendon. But Dion Bazadno did it for me, and I'll show you the results later on of the bench testing. Then the final explantation was after 32 weeks or 8 months. And here you see a beautiful tendon. There's the chin, there's the tongue, and there is the new biological tendon. Here's another picture, the mucosa of the tongue, the base of the chin, and the new biological tendon. It measures about 7 centimeters, 8 centimeters long. And that's it in cross section. And look how strong it is. It can actually hold, as I said, more than 60 newtons. 2 of my sheep became infected, which one expects. They are sheep and they have their own way of going around their daily business. And this is a test vehicle that was also infected. And then in bench testing after, this is the strong material called the polypropylene, which is non-absorbable. This is that material I put, the mesh I put into human beings. It doesn't absorb, it remains, it keeps its strength. But look how nice these 2 ones. These ones is the vehicle. And we can see with time, it gets stronger while the control gets weaker. So as more and more collagen gets formed, the tendon gets stronger and this gets weaker. And the polypropylene remains the same. And this is final. This is the last Western blotting showing us against collagen 1 and 3 quite mature. And this is my final slides showing you under high magnification. This is low magnification. You see how beautiful the intermingling of collagen is with the perimecium and the muscle and how it attaches to bone. And if you look under high power like this one, we can see the beautiful parallel lines of collagen intermingling with the perimecium of the muscle. So this is a truly biological bond between muscle and collagen. And we renamed it and we called it the biological tendon tether technology. And this is the future. This is how I'm going to grow tendons or these tethers in human beings. We published this work in 2020, and Sharon Prince helped me a lot there. And so did Dion Bazadno, and I thank all these people for being so amazing. Jos Hiller, and I had a student from Germany, Elena. I had a very nice team, and we published the sheep study in one of the best journals in tissue engineering. It's the second most read journal in tissue engineering. And then just lastly, I want to tell you about my welding machine. Have I still got a minute? My welding machine, they wouldn't allow me to use or hire a welding machine from Johnson & Johnson in America. So I found an old patent of theirs, and I copied this patent, and I found myself a mechanical and electrical engineer, and I built my own welding machine. There's the power source. There's the horn that carries the ultrasonic wave, and we just made this little jig. And you see over here, I've got 3 little towers, and I plait it like somebody's hair around these 4 strands. And then I just take it like you iron your pants, you just iron in between, and voila, look what you get. A beautiful, flat, nicely buttonholed little device. And this is how the device looks. And then we've got a temporary patent on it at the moment. And in the patent, it just shows a technique not dissimilar to the one that I did in the 2012 study. And this will be the future of putting a device into the tongue, which will eventually become your own tendon, something grown by you with your own stem cells. It will not reject, it will not become infected. And this is just a layout of the study, a level 1 study that we want to do. Surprise, surprise, I got contacted by Nature magazine, and they asked me, what are you up to? And I said, look what I'm doing. And so there's a little article about me in there. Thank you very much for your time. I really enjoyed giving this talk, and I'm looking forward to having a nice conversation. Thank you.
Thank you so much, Rushdi. That was fascinating. Could I ask you to stop sharing your screen so that we can then see? Oh, there we go. Everybody there. Thank you. So this is an opportunity now for everybody who would like to ask questions or make a comment. And there are a couple of comments already in the chat line. So let us take those first of all. You should be able, ladies and gentlemen, to raise a hand. Looking at the bottom, if you're looking for the place where you want to raise a hand, it's under the little button that's called reactions. If you click on that, you'll find an opportunity to raise a hand. But in the meantime, there were 2 questions. The first was in terms of the treatment of patients, human patients, whether or not there was any speech problem or swallowing or discomfort after the operation. So I don't know if you, the second one is from Professor Ravitsky, who is saying, how does one treat a UPP that hasn't worked? So perhaps you'd like to take those 2 questions first.
Thank you very much. Can you hear me?
Yes, we can.
Okay, so the first question had to do with, what was it again? Sorry.
It was about whether there was a problem with speech or swallowing or any discomfort.
Yeah, so these patients, obviously the one thing that I was not proud of was that the polypropylene mesh is quite a firm material. And that is why I cut it only in a 1 centimeter strip. And most of these people in whom I have just done an advancement of the tongue, their speech was fine within a month. Then the ones in which I made their tongue smaller, now whether I put a mesh in or not, if I had just made the tongue smaller, they would have speech problems in the first 2 or 3 months. But even those patients, only one of them replied to me and said that they couldn't say they are properly. But basically, speech, swallowing, kissing, singing happens as per normal. Why? Because I put this thing quite deep into the floor of the mouth. It's not superficial, it lies quite deep down. And it doesn't really interfere in the lateral movement of the tongue and the deglutition process, which is the swallowing process. So yeah, I must say I didn't have too much problems with that. The second question, I think, was Professor Rebecki.
Yeah.
He asked a question, just repeat it, please.
How does one treat a UPPP that hasn't worked?
Let me tell you something. The UPPP is a devastating operation. I had it done to myself. And once it's been done to you, that tissue has been cut away. Your soft palate has been cut away. Your uvula has been cut away. You can't return that. However, I now understand that the ENT surgeons now are a lot more conservative, and they sort of do a fold-in procedure now of the uvula. They don't cut it away as radically as they did before. So hopefully the new people who have UPPPs shouldn't have it as radical as the one that I showed you on the slide. But yes, sir, you can say to Professor Rubicki that I feel very sorry for him, like I feel for myself.
Thank you. And then there is just a comment, which is that this is a wonderful piece of innovation from recognized physical principles. It certainly is. For those of us who've ever done any polymer chemistry or looked at any of these kind of cell culture techniques, it certainly is amazing.
Thank you.
Are there any other comments or questions that anybody would like to ask? Oh, there's a question which says, why sheep and not dogs, for instance?
A very interesting question. Firstly, I wanted an animal which is large, more towards the weight of a human being. And the sheep weighed about 75 kilograms, whereas a dog would be only about, say, half of that or 1/3 of that. And the other thing I liked about sheep was they're social animals, and they usually eat clean things like grass, whereas dogs eat anything. And, you know, I wanted there to be a certain degree of oral hygiene as well. And that's why I chose the sheep. And just out of interest, these were virgin sheep that I paid a lot of money for from a farm in Stellenbosch. And I must tell you, these virgin sheep gave birth to a nice little lamb called Mary. I gave it to somebody in Noordhoek.
Thank you. Any other questions before we close? Anybody? So, Professor Hendricks, I can just say there are some very complimentary comments about how educational and enlightening your presentation has been, how fascinating, and just how interesting. I have to say, I have to agree. I started this evening thinking this is not the kind of talk that I would normally expect to find just as enlightening as it has been. And I think we should congratulate you, not only on the educational part of this, but on the amazing innovation and your obviously a long path that you have followed to get from where you started to where you are now. And I hope that your patent will be approved, that it will be internationally approved, and that this will go from this point to being a real application that becomes, I don't know what you call it in surgery, but a successful application, and obviously something new which can help many people. So I'm humbled at your expertise and the approach that you have taken. And I would like to say on behalf of everybody who's listened to you, thank you so much for enlightening us and for inspiring us. I'm sure that there are many people who have listened to this who are inspired at the fact that somebody can follow this kind of intention, this kind of dream, and get to this point. And finally, let me say, we wish you well in taking this forward, and I'm sure your colleagues in surgical practice of various forms will follow this with great interest. So I think we have come to the end of that, but would you like to say any more in closing before we finish?
Yes, thank you very much. I'm really humbled by your wonderful words, and I didn't think that when I was asked to address the Royal Society, and I've been to many Royal Society meetings, I thought to myself, oops, I wonder how this one will go down, because there's a lot of blood and gore and so forth. But thank you very much for listening to me and sharing your expertise. And I really enjoyed being on the air and talking about what is really passionate to me. And I do believe that we are now starting on the level 1 study soon. I do believe that it will one day come into the open and help a lot of needy people. Thank you so much for having me.
And congratulations on your first Zoom presentation, Professor. It was extremely successful. So thank you so much. So ladies and gentlemen, I think we have come to the end of the seminar. I would like to thank you again for your attention. And I hope that you will have enjoyed it and been as inspired as I have. I wish you all well. I hope that you will all stay well and have a good evening for the rest of the evening. Thank you. Goodbye.
Goodbye.